Thank you, Chairman. Ladies and gentlemen, it's my great honor to talk about the fertility preservation update. The first talk is about for the male, advance in fertility preservation for boys and men by Dr. ESHRE. This presentation was an overview of current knowledge in fertility preservation for males. The emphasis was on the prepubertal patients who do not yet produce sperm. For mature men, fertility preservation is usually a matter of storing sperm from ejaculate. It's easier. But review was on cryopreservation of testis tissue, which either mature or immature. Removal and cryopreservation of testis tissue is still experimental, so it was recommended obtaining ethics committee approval. It is a complex procedure, so requiring a multidisciplinary team, largely confined to the special centers. Results in the human are not yet available because the time from cryopreservation to demand for sperm is usually more than 10 years. However, fragments from immature testes have been shown to reach full spermatogenic potential when grafted into monkeys. The testis has high regenerative potential, so the sperm can be generated from cryopreserved tissue by germ cell transplantation, testicular grafting, or in vitro spermatogenesis. This algorithm for the patients were exposed to the cancer therapy with chemotherapy. For the mature men, the patients can deliver sperm sample, so it can, cryopreservation of sperm. But for the patients, such as boy, he's unable to deliver the sperm sample due to immaturity. So we have to cryopreserve the testicular tissue. For the patients with low risk of metastasis to the testis, it's easier. When the patients complete the chemotherapy or surgery, we can do the defreeze the tissue, then transplant to the testis. It's so-called germ cell transplantation. Or we can do the ectopical autografting to another site of for the testicular tissue. But for the patients, risk of metastasis before transplantations, we have to do cell sorting to deplete the cancer cells or enrich the stem cells, spermatogonium, then do the transplantation or ectopical grafting. But we can also consider to do the xenografting to the animals. Caution is needed as there are large lymphatic spaces in the testis, so the incidence of metastasis of primary cancers to testis is high. Now close to understanding how to produce sperm-producing cells from stem cells, this is likely to be the preferred method of fertility preservation for male in the future by the stem cell. The conclusion, the male fertility preservation, mature males can store sperm samples, but other techniques are required for prepubertal boys because they do not produce sperm. Sperm can be regenerated from cryopreserved tissues by germ cell transplantation, testicular grafting, or in vitro spermatogenesis. Removal of and the cryopreservation of testicular tissue is still experimental, and requires a multidisciplinary team at a special center. Proof of concept has been achieved in animals such as monkeys. Fragments of immature monkey testes have reached full spermatogenic potential when grafted into animals. The cryopreservation procedures has been performed in humans, but the results not available because the time after freezing and thawing and transplant usually more than 10 years, waiting for the recovery from the chemotherapy or when the patients are married. Our next talk is about the female, the reproductive outcome after fertility preservation in girls and the women. It's by Dr. Miro. The presentation reviews current evidence on reproductive outcomes after fertility preservation methods in females being treated for severe disease, principally cytotoxic chemotherapy for malignancy. The principal methods available for fertility preservation in females are IVF, or oocyte freezing, or removal of ovarian tissues, and regrafting of ovarian tissues. This talk emphasizes on the ovarian tissue freezing. Results from IVF or oocyte freezings for the patients immediately after chemotherapy are very poor. And in addition, the animal studies show an increased risk of abnormalities. So we usually recommend do not collect mature or immature oocytes for fertility preservation in patients recently exposed to chemotherapy in 6 months. The chemotherapy usually will damage the larger follicles, such as secondary follicle, pre-entrant follicle, entrant follicles, but is less toxic to the primordial follicle. So after the chemotherapy, the ovarian stimulation response is very low, or even no response. And we have mentioned the animal studies show we get the oocytes immediately after chemotherapy may have a risk of chromosomal abnormalities or abortions or malformation. Grafting of frozen ovarian tissues back to the ovary has resulted in dozens of live births, both natural pregnancy or after IVF. However, most follicles are lost immediately post-transplantation as a result of burnout because the vascular system cannot be immediately reestablished. Efforts are being made through ESHRE to collect data on success rates with different procedures. Minimal residual disease has been detected via PCR in samples of prior preserved tissues. These are some problems for testicular cryopreservation. There's a risk of metastasis of the cancer cells to the ovary. So the samples before transplantation has to be examined for residual disease of cancer cells at a special center before grafting. A conclusion, cryopreservation and regrafting of ovarian tissues is effective and should no longer be considered an experimental strategy by the author's opinion for fertility preservations in severe disease. Reducing loss of follicles due to burnout, due to the blood supply establishment is key to improve effectiveness. So we have to identify mechanisms to reduce the burnout effect will be crucial to improve the success of ovarian tissue grafting. The technical improvements and standardization will continue. data need to be collected on success rate with different techniques. Creation of specialized fertility preservation centers is recommended because it's highly specialized centers should be used for assess tissue samples for the minimal cancer residue. The third talk, we would like to talk about a novel method for cryopreservation of very low sperm by Dr. Sting. The growing use of various surgical methods for testicular sperm extraction, the TSE, in azoospermic patients raised the need for an efficient cryopreservation methods of very low count sperm. Current sperm cryopreservation methods are usually handle large amount of sperm, but it can be associated with loss of considerable portion of spermatozoa. So a simple or useful sperm cryopreservation methods can be beneficial not only for azoospermic men performing the TSE, but also for cases of extreme oligozoospermia. So the aim of this study was to develop a new, simple, convenient, efficient cryopreservation method for very low sperm count samples. The patients included 20 samples from very severe male factors, so-called oligo-asceno teratozoospermic patients, OAT patients, and 10 azoospermic patients undergoing the TSE procedures. They used the device CryoLock to carry the little amount of sperm, and you use two kinds of cryoprotectants, testicle buffer and the glycerol, and the two freezing methods. We can see the pictures is a CryoLock. It's similar to our CryoTop we usually use in Asia, and put the very little amount, minimal amount of the sperm samples mixed with the cryoprotectants on the tip of the plastic. So, and lock. It keeps the samples for room temperatures about 10 minutes. And they use two kinds of cryoprotectants, a testicle buffer with glycerol, and the other is a herpes buffered salt solution with glycerol glucose, and freezing with two methods. The first is the keeps on the vapor phase. The second is kept in the liquid nitrogen. The results for the OAT samples, 20 OAT samples after thawing, all of them can get the sperm. And the motile sperms can reach 95% in the samples. Means the 19 samples have at least one motile sperm. The results is better for vapor phase, the green color we can see. But if we put into the liquid nitrogen, the results much less. And on the left column is testicle buffer. So the testicle buffer has better results than the glycerol glucose medium. For the TSE samples, the 10 samples have 9 can find the sperm, and in the 9 samples, there are 4 samples have motile sperm. This is the data from the vapor phase. So the conclusion, the present data demonstrates that it is possible to successfully freeze low count sperm samples and the surgical retrieve sperm with minimal post-thawing damage. The recommended protocol is mixture of the sperm with test yolk buffer cryoprotectant 1:1 for 10 minutes at room temperature, followed by exposure to the liquid nitrogen vapor phase. It is simple and efficient, and no need for special expensive equipment, and the special skills are not required. The device, CryoLock, and the cryoprotectant are commercially available and proved safe for cryopreservation small numbers of human sperm. The first talk is about the oocyte bankings for aged women. For anticipated gamete exhaustion, it means AGE, a follow-up studies by Dr. Stoop. The aim of this study was a follow-up study of oocyte banking for anticipated gamete exhaustion for the aging women, assess the relation status, the marriage status, and reproductive history of women, and to evaluate why some women decided to bank and why others did not do the banking of oocytes, and how women look back on their experience to do the oocyte freezing. It is performed by the standardized telephone questionnaire and the cohort of consecutive candidates for AGE indications for oocyte freezing. And the contact at least 1 year since intake means doing the oocyte freezing. So after consultation, 152 intakes was included, but only 138 accepted this investigation, and including 86 do the banking and 55 do not do the banking, and 65 get consent and in the banking group, and the 31 in the non-banking group get consent. The age of oocyte freezing is mean age is 36 years old. There's no difference between the non-banking or bankers. And they are single, the non-married is about 80% between the two groups, similar. The age of follow-up is about 38-year-olds. The reasons, the motivation they do the banking oocytes for age problem, the first is I wanted a kind of insurance against infertility. The second is I wanted to buy more time to find a partner. The third, I wanted to have try everything to optimize my future reproductive chances. The fourth, I wanted to take away the pressure to find a partner immediately. About the relation of children, desire for children and relation and pregnancy attempts, the bankers have 65 data and the non-bankers 29. Do you still have a desire for a child? Almost 90, more than 90% want a child. The relation at least 6 months since oocyte freezing, about 50% have the marriage relation. What do you consider for yourself the maximum age for pregnancy? They think in the banker group is about 43 years old, and the non-bankers group is 42 years old. So it's a significant difference between the two groups. Have you tried to conceive since oocyte freezing? Yes, about 35 to 45% in two groups, no significant. Have 9 pregnancies in banker groups and 3 pregnancies in non-bankers groups in recent years. There's no significant differences. The ongoing pregnancy rate is also no difference between the two groups. The two groups receiving the ART or donor sperm are also not different to achieve pregnancy or spontaneous pregnancy. For the non-bankers, regrets about the non-bankers do you regret not having done the treatment? No, most of them no. They do not do the oocyte freezing for non-bankers. Would you have done it if it would have been considerably less expensive? Yes, 45%. So it's cheaper, maybe more acceptable for these non-bankers. The attitude towards alternatives, adoption. For bankers and non-bankers, yes, about the 30%, they will receive adoption. Its attitude to childlessness, no children, no. Most of them cannot accept no children. For the bankers, oocyte banking for them is a positive experience. No person from bankers express regret. And 95% would like to do again. And also they would like to advise their friends to do the oocyte freezing. About the future use of the banked oocytes remains uncertain. Do you think, for the bankers, do you think you will ever use store eggs? Yes, about 50%. Do you consider the use now more likely than at the time of freezing? Yes, 21%. Do you consider the use now less likely than at the time of freezing? 29%. So from the time, maybe the uncertainty will increase. So the conclusion is, for the oocyte banking, it's positive experience, no regret. 95% will do it again, and most would positive advise others. Future use of oocytes is uncertain. Only half think they will use them. 29% consider the chance of using them lower than the time of oocyte freezing intact. The donor sperm is the most popular alternative I think it's in Europe, because the donor sperm for single women is not allowed in Taiwan, maybe in other Asian country. Conclusion, oocyte banking. The main reasons for not having do the oocyte freezing is uncertain expected outcome. I think the outcome is much improved in recent years for oocyte freezing. The price, almost half was considered. If the lower price, they will do the oocyte freezing. And no difference in bankers and non-bankers about the desire for children, they like children, and the relations and pregnancy attempts. Those who underwent the procedures accept a significant higher maximum age for motherhood for the bankers. The last 3 slides, I would like to share our experience about the oocyte freezing. The first case is 25 years old. She is suffering the blood disease of myelodysplastic syndrome about 7 years ago. Before chemotherapy, she come to our centers, referred from our oncological department, underwent the control ovarian stimulations, and we get the 38 oocytes. We do the slow freezing at that time. After bone marrow transplantation, she has premature menopause. In this year, 30 years old, she got married, and we saw 22 oocytes, and the 20 are survived. the survival rate is about 90% in this slow freezing. And we have 13 metaphase oocytes and do the ESHRE, and 10 fertilized. And we got 6 blastocysts. And we do the single embryo transfer and get the ongoing pregnancy rate now. And so the lady still have 6 blastocysts cryopreserved, and also have the 16 eggs still preserved in our bank. The second is we do the oocyte vitrification for an unmarried female. When this lady was 39 years old, is single. In about 2 years ago, 3 years ago, he come to our hospital to do the control stimulation and the oocyte retrieval. In 2 times, we get 12 oocytes and vitrified. When she was 40 years old, she got married, and he had infertility problems after 1 year. Then he come to our hospital to defreeze the oocytes. So we thaw in the oocytes 12, and 100% survived from vitrification and thawing, and 11 fertilized by ESHRE. She got a pregnancy, it's a twin pregnancy. Now she still have the 3 blastocysts that were vitrified again in our bank. So the oocyte freezing has become more popular, more and more popular in Taiwan. And in our hospital, the social freezing is much increased recently. So it's occupied about 70% is so for social freezing. About 30% is for cancer patients. So we are cooperate with the oncological department. We suggest freezing the oocytes before the chemotherapy. Thanks for your attention.
We thank Professor Chen shares so many effective information regarding update on fertility preservation. I think maybe 10 years ago, it's not very easy to freeze an egg, but after vitrification, there's a lot of efforts for that. So I wonder, is there any question or comment from the, yeah? Mao?
Ma Caihong from China. So very interesting lectures. And I'm just asking you, as you know, in China, we are discussing if we should establish an oocyte freezing bank, and especially for the couples, they lose their child during the after menopause, especially and they just one child policy in China. So that's a big problem for some couples. So what's your opinion, and do you have some suggestions to this? And second question is, in your university, you just preserve the oocyte, but not the bank, right?
Yeah.
So do you, is there some oocyte bank in Taiwan?
No. Because our oocyte donation is 1 by 1.
Okay.
So you just watch one woman for special one and special recipient. We cannot do the oocyte banking and to provide the oocytes to several couples. It's not allowed. So oocyte banking for oocyte donation is not a common practice in Taiwan, because we cannot provide oocytes for many couples, just 1 by 1.
Yeah.
So it's oocyte cryopreservation for herself, just for herself. And for the cancer patients, I think we should do that because even in the China mainland, because the cancer patients will lose their fertility.
And also in our center, we perform the preservation of values.
But for the social freezing, it's not still allowed in the mainland China.
Yeah.
But it's a very, very.
So what's your opinion? Do you
for me,
support to
for the
establish
unmarried woman,
support
such as
the bank?
she can find a good person at that time, I think I will do that. Actually, we do. Yeah.
But how to help the couples, the after menopause?
Couples after menopause.
Yes, after reproductive age, probably 85 years old.
85?
No, not 50 years old. 50 years old, sorry.
20
So
years old.
after the earthquake in Sichuan province, many couples lose their child.
Yeah.
So how to help them?
Lose
So this
their
is a
child
pro-
after
yeah.
earthquake. I think
There's a country's policy, one child.
yeah.
So do you think that's
But if
just
after menopause, I will do oocyte donation.
Yes, what's your opinion? If we should establish oocyte bank?
Oocyte bank to help infertile couple.
No, not to help, just if the possibility or the necessary to establish oocyte bank in China. What's your opinion?
That depends on your policy, because if you can
Thank you.
and one donors for several recipients, I think oocyte bank is very helpful. It's common in USA. In USA, have 10 centers with oocyte banking. They do the vitrification or slow freezing. They provide the whole country, so it's commercial in USA. But in China, I don't know. This is commercial, maybe not allowed. But I sense oocyte banking will help couples. Yeah.
Yeah, I think Dr. Mao is talking about egg sharing program. I said we have a similar situation like the United States. You can take about egg sharing. So Ina, yes, please.
Thank you for your speech. I was wondering, for those women who come into our clinic and asking for ovarian preservation due to social reasons, do you think that do we need to test for their ovarian reserve before we do this? We are going to the preservation, like testing for AMH or FSH. Do you think that's helpful?
I think so the lady will like to the outcome of their freezing or eggs, because the age may be the most dependent factors, has been mentioned by Dr. Diego, and also the AMH or antral follicle count or FSH level we will detect, and after these data we will explain the expected outcome. But usually I think a recent advance in ART, maybe the woman less than 42 years old, we have chance to get pregnancy, because these ladies are not infertile. You just cannot find a man. So the egg quality usually is not bad. So I think we can help them if we have more data to tell them the outcome, and they will do that, usually.
Yeah, you mentioned about social banking of oocyte, right? If according to ESHRE and practical guideline, there are some evidence you freeze the egg less than 35 years old. They probably have some evidence to have a fertility after that. But if you freeze the egg more than 35, it's still a controversial issue for this. Yeah.
Okay.
Yes. No more question or no more comment? Okay, then we thank Professor Chen again for his great contributions.